Here's the bottom line. PCR NGS as the new standard. That was the task at hand, not for specific uses, but as the new standard, may lead to antibiotic overuse, consequences of which we just can't anticipate. Dr. Anger did a great job explaining our previous approach was to eradicate all urine of bacteria, and now we know that some bacteria act intracellularly, others just attach to the surface. We really want to treat a proven and symptomatic UTI versus eradicate all bacteria. So culture and sensitivity, while it has some limitations, it can't detect fungal, anaerobic bacteria, genital urinary tuberculosis as much. Let's talk about the advantages and disadvantages of NGS and PCR. Bottom line, again, NGS can detect more comprehensive data that culture does not, but we don't know the quantities. So it's there, but is it in fact changing management? Is it causing symptoms or not? We are also limited by the quality of these public genomic databases. So that's what the microbial DNA is compared to and matched to. But if that quality could be better, then we actually don't know how well that matching is. PCR, definitely some advantages. It's picking up more pathogens than culture. We do know the quantities, great. Now, back to what Dr. Anger said, we are very limited by we have to determine what are the panels that we're looking for in order for the PCR test to actually identify those. So if anyone has a crystal ball here, PCR is going to work well because you already know what you're looking for and it'll find it. But if you don't know what you're looking for, good luck. Overtreatment, overtreatment, overtreatment. We need to treat the amelioration of symptoms. We need to prevent pyelo and sepsis, period. We're not about looking for bacteria to treat. And unfortunately, antibiotic resistance has gotten worse with the COVID pandemic. And what are we preventing? Our colleagues Foxman and Christenens have told us that pyelo only occurs in less than 4% of antibiotic or non-antibiotic treated patients, and symptom duration reduced only by 1 to 2 days in patients treated with antibiotics. There are thankfully many, many studies looking at PCR NGS versus culture. Unfortunately, as we're very familiar in research in the scientific world, the bottom line is more studies are needed. This study in particular did not look at changes in care management. If we're not doing that, why? Why study this? I'm baffled. They also had a low power, and this study that Dr. Anger mentioned showed that 90% of the PCR and culture and sensitivity results were actually comparable. Okay, great. But they did not look at patients who were asymptomatic. So again, we found the bug. Did we find an infection? Cost, we are going to absolutely burden our healthcare system, our overall GDP if we start using NGS PCR as the new standard. Anyone else affected by MolDX limitations this year? I know I'm not alone, unfortunately. All the orange states in this map, we had reimbursement, and then we didn't. Accessibility is limited. I have colleagues at a prestigious academic institute in Chicago. They can't use it because they don't have it. So would we make anything a standard that costs us more? Not everyone has access to, and most importantly, can in fact cause more damage because we're not clear if we're distinguishing between uropathogens and normal urobiome. We don't have enough evidence for care management. We also don't know what the consequences are that overuse of antibiotics will cause. And we can, however, use it when in limited cases, right? We can use it when we have negative cultures and an infection strongly suspected, when we have these recurrent UTIs that our culture is not helping with. Also want to limit to specific specialties and not our generalists. And finally, a test, because it shows us more things, does not mean that we are treating the patient better. Clinical judgment is and always has been key, and we must do no harm. Thank you.